Today, we are honored to have Dr. Soira Sokwala, who is an endocrinologist by profession.
Inhibitory means it stops the function of the thyroid hormone, which we call 𝗙𝘂𝗹𝗃𝗏, thyroiditis. Or it could be stimulatory, which increases the function or the production of the thyroid hormones. We got a lot of cases after COVID, post-COVID thyroiditis. Or it can even grow inwards into the neck. So they may have difficulty in swallowing, difficulty in breathing, choking, So they get this excessive weight loss because everything is fast mode. So metabolic rate is excessively increased. You're eating a lot, but you're losing weight. Now, Graves' disease especially comes with another important feature, which is quite classical of Graves, is associated with the eyes. So there's a student that came to us, and basically he was labeled to be a drug addict, actually, even in school. He had all these symptoms and his eyes were bulging. It's typically appearing like someone who takes
on drugs.
On drugs.
Join us at Health Talk Desk. Make sure to subscribe, like and share our videos to keep spreading vital thyroid health insights.
Good morning, good afternoon, good evening, wherever you're joining us from. Welcome back to the Health Talk Desk, where we talk about everything and anything thyroid. And remember, if you haven't subscribed, please do so. Click the notification bell, and then if you have any questions on the comment section, hapo chini, put in your questions there. Today, we are truly honored to have the very first session of having a doctor on Health Talk Desk. Today, we are honored to have Dr. Soira Sokwala, who is an endocrinologist by profession, and she will tell you what endocrinologists mean. I didn't know that. So today, let's welcome Dr. Soira Sokwala. Doctor, most welcome. It's good to have you on board.
You.
First of all, I just want you to introduce yourself. Let the people know what the term endocrinology means.
I'm thank you very much for inviting me and for having me to be able to educate our people on thyroid disorders or thyroid diseases. I'm an endocrinologist. Like you said, endocrinologist simply means that I deal with hormones in the body. Hormones affect every part of your body, basically, from the head to toe. Every part of the body has some function with hormones. There are some hormonal glands in the body. Diabetes is also a hormonal problem. Thyroid disease, pituitary, adrenals. I think we could talk on and on, but that is what an endocrinologist does, is basically dealing with hormonal issues that you have in your body. I am currently working in the Aga Khan University Hospital here in Nairobi. And I'm a mother of one.
Oh, nice. Very nice to hear that. So if we can and if you have any questions in the process, please put them in the comment section below. But we first of all want to understand, because we're here to talk about thyroid diseases. What is thyroid? For somebody who doesn't know, what is thyroid? If we can start there.
So thyroid is a gland, and it's a structure located in the front of your neck. It's a butterfly-shaped gland that is right here in the front of your neck, which has significant function in the body, and it actually produces some hormones, which are these substances in the body, which control a lot of the functions of our body. So it produces two types of hormones. Simply put, there's the T3 and the T4. So these hormones, they actually are so useful in quite a bit of functioning. Like the heart needs these hormones to control the heart rate, to control the pumping of the heart. These hormones control your basal metabolic rate as well. And they also control mood, like the brain functions. They have a role in the liver function. They have a role in your bone turnover. They also have a role in the reproductive system, like your periods and, ability to have children and stuff like that. So it has a wide function in the body, and it's a necessary organ in the body.
Yeah. Oh, that's wonderful to know. So if you didn't know that, I'm sure you're learning. Now we talk about thyroid disease and thyroid disorders. So if maybe a patient is experiencing certain kind of symptoms and it is difficult for them to connect those symptoms to a thyroid disorder, how can you define what thyroid disease is in relation to what you just explained?
So Thyroid disease is a very broad term, right? So there's a lot of conditions that are associated with that terminology of thyroid disease. So I told you about the normal thyroid, but sometimes issues can happen where your thyroid functioning gets messed up a little bit, because it's a very active organ, and any very active organ can actually get diseases quite quickly, because there's continuous formation of the thyroid hormone going on and all that. So you can have either very low levels of thyroid, like if you've got, we'll talk about the causes I believe, but if you've got like problems which are affecting your thyroid, let's say someone has got the thyroid removed for any reason, or they got radiation done to the thyroid gland, that can reduce the functioning of the thyroid. If you're, for any reason your thyroid is not functioning, then that is called hypothyroidism, where you've got low levels of thyroid, or you can have hyperthyroidism, where you've got excessive production of the thyroid hormone in certain conditions, which is either related to destructive issues that cause the thyroid hormone to be released, like infection of the thyroid, or you can get excessive production of the thyroid hormone due to certain conditions, like there are some things known as autoimmune diseases. Autoimmune means that your body's immune system works against itself. Yeah, so when you get that, then that means that it can be either inhibitory, means it stops the function of the thyroid hormone, which we call 𝗙𝘂𝗹𝗶 thyroiditis, or it could be stimulatory, which increases the function or the production of the thyroid hormones, which in that case we call as Graves' disease. So those are like the common ones. And then you can have issues with iodine deficiency. If you don't have iodine, you can get reduction of the production of thyroid hormones, and you get these goiters.
Yeah.
So you can have big goiters, like in some areas, even in Kenya, in the mountainous regions, you can have low iodine levels. So that can cause goiter production. So the neck is big usually. Yeah. So that can predispose also to low thyroid levels. Then there's this big group of nodules in the thyroid. So there's growths in the thyroid gland, just growths, which can be either functional, which means they are producing thyroid hormone, or they could be non-functional. That means that they are there, but they are not causing any extra production of thyroid hormone. And that is, there could be one or multiple. So when there are many, we call it multinodular. We call it goiter. When the thyroid gland is enlarged, we call it a goiter. Yeah.
Okay.
And you can go towards now the conditions associated with thyroid cancer. So the growths that I was talking about could either be benign, which is now the nodules, that are the benign nodules, or these nodules could become malignant, that means cancerous. So the percentage of cancer in nodules, it varies by region. We don't really know the prevalence in Kenya, but overall in Africa, you can say up to about, if you have a nodule, then the prevalence is about between 2 to 5% from where the studies have been done, although we know we have few studies. Yeah, so those are some of the common causes of thyroid disorders.
Yeah. So you mentioned something about iodine, and I realized that there's a mainstream narrative that iodine or lack of it could be the only thing. Like most of the times when you go to a shop, or maybe somebody just sees you with that growth, they'll tell you iodine, or take this iodine. Why do you think that narrative is there up to now, and yet we are having so many cases that have so many other underlying conditions other than just iodine deficiency? Do you think that iodine deficiency is the only cause, and do you feel like that narrative needs to change? Yeah, right now where we are, considering that we are seeing prevalent cases of thyroid disorders coming up?
It's actually a brilliant question. The truth is that in Africa, in some parts of Africa, even now, iodine deficiency is the most common cause of goiters. Okay? But in Kenya, there's a blessing that we have. Our salt is iodized, right? And this has changed the narrative.
Right.
Actually. So in Kenya, like the cause issue of thyroid disorders or big goiters has changed from iodine deficiency, now moving more towards other causes like I talked about autoimmune, where your body's immunity destroys your thyroid gland. So it's called 𝗙𝘂𝗹𝗶. So then now that also can cause a goiter, right?
Yes.
So it's not always iodine deficiency as the underlying cause. I think that's what answers the question, is that there is a lot of other causes that can happen.
Yeah.
And many a times you may not even know the cause, actually, and it can happen without a known cause. Yeah.
Oh, really?
Yes. So thyroid disorders can happen to anybody, and that's the message I want to actually bring out. Is it can happen to me, it can happen to you, it can happen to anyone, even to children, to
Yes.
adults, to very old people. It's not something that is just for a particular group of people. Let's say just a particular group living in the mountains, or a particular group who have iodine deficiency. It can happen to anyone.
So it can happen, so it has no cause, because my next question would have been, what do you think is the trigger?
Yeah.
Especially right now that we are seeing a lot of thyroid cases coming from children being born with thyroid disorders, all the way through to the people the age of 65, I believe it is. So is there something that maybe we can pinpoint, or we can tell a patient, okay, look out for this to see if you have a thyroid condition? What do you think could be the trigger? Because I know there are times when we talk about some of these thyroid disorders, somebody will sit down and say, that is me. But they are really not able to put a finger on
Why me?
why me. Yes. So can we talk about the fact that it is genetic?
Yeah.
Is it inherited? Or is it a lifestyle thing maybe? If you'd say, is it an aspect of nutrient deficiency? What do you think?
So it's an interesting question as well, because so the exact cause of why things happen, especially autoimmune, we don't know. Like iodine deficiency is clear that, we know that when you don't have iodine, your thyroid gland kind of grows bigger and tries to, compensate for that. So that's a known cause. Like I said, that's a bit lower now that we've got iodized salt in the country. But other causes, so there is usually the postulates now, like I said, the exact cause of this, even autoimmunity, we don't really know. Okay, but what is postulated, like all other autoimmune conditions, auto means self and immune is immunity against self, right?
Okay.
They happen because of a genetic predisposition. So there's a genetic component to it. It doesn't mean that your family member must have had it.
Okay.
You have a genetic predisposition. That means when you were born, you had that
Gene.
risk already there.
Mm-hmm.
Okay. And then on top of that, there could be some environmental factors which could have triggered it. So some things like, there are postulates, again, a viral infection, for example, in the past. So this is called molecular mimicry, which means that, you could have had a viral infection, for example, in the past, and your body recognized that as foreign and produced immunity to that, like the soldiers were produced to that infection. And then what happens is that there's a part of this virus which looks like your thyroid gland, and the body now thinks that is foreign,
Yeah.
and because you have a genetic predisposition,
So
and
it
this
fights
comes
it.
in,
Okay,
so it's
got it.
fighting itself.
Yes.
So the risk gets a bit higher, you see. So that's one of the factors, and you cannot pinpoint which virus it was, when it was. That's why I'm saying anyone can get it, yeah.
Okay.
But women, especially in their childbearing age, this age of about let's say 30s to early 40s, have a higher risk of getting autoimmune thyroid conditions. So you should be on the lookout as well. But I'm seeing more men as well. Even young boys I'm seeing coming in with autoimmune conditions, both the Hashimoto's and the Graves, the autoimmune aspect of thyroid disease. So those are some of the factors. Now there are also correlations with vaccines, they say, exposure to certain vaccines, and it's not yet established totally.
Okay.
There's a lot of postulates that certain vaccines could have caused, but that doesn't mean that we don't get vaccinated, because of course vaccines are protective, so the benefit outweighs the risk. But these are not concrete results that have been shown as yet. So that shouldn't be a belief out there that when you take vaccines,
Vaccine,
you're going
to get.
But that's a belief that some people have. It could even be a myth. But basically, it's not yet completely confirmed that. Especially after the COVID vaccine, we have a lot of patients saying, "Oh yeah, it's a vaccine." Yes, COVID itself was causing thyroiditis. So sometimes viral infections themselves can directly infect the thyroid,
Right.
and that is then called thyroiditis. That is inflammation of the thyroid gland. We got a lot of cases after COVID, post-COVID thyroiditis, and viral infections are known to cause some of the viral especially the like the SARS and like COVID. We were seeing actually the patients were coming with inflammation of the thyroid gland.
Yeah.
But that's usually temporary. It's usually short-lived.
Yeah. So once the treatment is there and it's done, it normally should go away.
But otherwise, seriously, I cannot say that there are fixed triggers to getting thyroid disease. Some nutrient deficiencies you talked about. So now we know that selenium, for example, selenium deficiency has been associated, or rather selenium replacement in a big study that was recently concluded, actually showed that replacing selenium in patients with Hashimoto's thyroiditis specifically improved their outcome. So that means selenium deficiency also, like you said, could be implicated.
Okay. So let's talk about the treatment options now that we've talked about. I actually didn't know about the thyroiditis aspect. That's very eye-opening. So let's talk about the treatment options now that what should a patient do? All right. We are out there. A patient is going through some of these symptoms. So let's talk about the symptoms maybe, and then we can come to the treatment options. For a patient that is experiencing before they are diagnosed clinically, officially diagnosed with thyroid disease, what should the patient look out for?
So thyroid disease can present in very interesting ways and very different ways. Someone can have no symptoms at all. You'll not know that you have. Sometimes, we get patients who have been referred just on a routine testing. So one thing that I would like to encourage is, especially if you're over the age of 35, even if you don't have any symptoms, just do your annual checkup. At least get your sugars checked, get your blood pressure checked, get your cholesterol checked, get your thyroid checked.
Awesome.
Okay? Because the prevalence is growing. And it's growing also because we are detecting it more, probably, right? And that's why we are seeing more and more numbers because of you as Thyroid Association of Kenya. You're creating awareness, so people are coming in more. But that's one reason why we are seeing the numbers are increasing as well. So just to know is like, at least get yourself screened. You may never know, you may not have the symptoms, but you have the condition, right?
Yes.
So that's one thing, is asymptomatic. Completely no symptoms, okay? Sometimes we get patients coming in with just having noticed a neck swelling. Someone will say, I was in a meeting and my friends noticed that there is something swollen on my neck. And that's the first time I picked it, or I was having a shower and I noticed there's some swelling. So a neck swelling is another common way patients will present with, especially females, because of the cosmetic aspect of it. Males, if they've got beards and all, it can actually get hidden in. But females, they tend to notice these things as well. So neck swelling. Some patients come with pressure symptoms. So before I go to the hypo and hyper, I'm telling you like the physical aspect of it, right? So some patients may have a neck swelling that's growing inside. So the thyroid gland can either grow out or it can even grow inwards into the neck. So they may have difficulty in swallowing, difficulty in breathing, choking, basically having hoarse voice, because especially with a very big goiter or big nodule growing in, it can affect the nerves that control your voice. So you would have hoarse voice as the only first presentation. Okay, or some patients, they cannot sleep well at night and they feel like there's something like many patients talk of a bend around their neck sensation if it's a big goiter. Sometimes patients now come with the symptoms of hypothyroid, that is low thyroid, or hyperthyroid or thyrotoxic, that is high thyroid. And what are those? Those are important to know. So fatigue is one of the most common symptoms of thyroid disease, whether it's low or high. I've seen even high, because your body is so overworked. So basically, when I told you that the thyroid does certain work, right, in the body, controlling your heart rate, controlling your pulse, controlling your brain functioning, controlling your liver and all those bone metabolism. So when you have got excessive thyroid hormone, then you are in speed mode. Everything is just running fast, right? So you got your heart rate beating very fast, so you get anxiety, you get your heart, you feel, it's called palpitation, so you feel that your heart is beating very fast. Sometimes you get this feeling of actually mood disorders, so they get anxiety, they get just getting annoyed left, right, center. You don't know why you are getting, even at the end of the day, patients tell me, I don't know why I'm getting annoyed, but I'm just getting annoyed. I'm just getting upset. Everyone at work is upset with me. I'm upset with everyone. My relationships are being affected by that. So my mood swings are so huge. And that's one very interesting. Sometimes even patients are sent from the psychiatry clinic to us because they went there mainly for depression, and a good psychiatrist decided to do the thyroid function test. So psychological disturbances like mood problems, anxiety, as far as high is concerned. So you have more of anxiety in the hyper. You can have, when you're looking at hyper still, because everything is working fast, your basal metabolic rate is increased. You can even have, heat intolerance. So they feel like it's excessively hot. Even when everyone else is feeling cold. They feel excessively hot.
Yes.
Yeah, so in the office as well, patients may want to put on the AC in August in Nairobi, when it's cold, and that's the kind of, and then the guys around them actually tell them something is clearly wrong with you. The temperatures are so cool, and you're feeling so excessive heat. They can even get excessive night sweating. Okay, some patients, the thing that brings them for the first time is weight loss.
Okay.
So they get this excessive weight loss because everything is fast mode. So your metabolic rate is excessively increased. You're eating a lot, but you're losing weight. That's a very prominent symptom to look out for thyroid disease as well. And patients have been labeled to have HIV as well, sent for HIV evaluations, and stigmatized based on that, just because they are losing weight. But this is one of the features as well of thyroid disease. Now, Graves' disease especially comes with another important feature, which is quite classical of Graves, is associated with the eyes. So basically, if you've got, it's called Graves of ophthalmopathy. It's like your eyes get affected by the autoimmune condition, and then there is reddening of the eyes. So you'll see a patient with bulged out eyes, with reddening because now it's inflamed, right? And you're not able to close your eyes, so you get dry eyes, watering. So there's a student that came to us, and basically he was labeled to be a drug addict, actually, even in school. He had all these symptoms and his eyes were bulging. It's typically appearing like someone who takes
on drugs.
On drugs. And it's not a nice sight when you see someone who has got an eye issue. But that's one of the features also. So if you've got this combination of losing weight, excessive palpitations, heart beating, and you're getting someone who's tired all the time, overworked, anxious, mood problems, you have to think of hyperthyroid or excessive thyroid hormone production. The other spectrum is the exact opposite, is when everything now goes slow mode, right?
Yes.
So now you get hypothyroidism, low thyroid, where now again fatigue is even more prominent in that condition. You get excessive fatigue. You're just sleeping all the time. You want to sleep. So in hyper, you get insomnia, which means that your sleep patterns get disturbed as well. So you can't sleep too well, right? Whereas now in hypo, you'll be sleeping all the time. They're drowsy, they're sleepy, they're gaining weight. It's the exact opposite, right? They've got dry skin, losing hair, especially the eyebrows. If you start seeing your eyebrow hair is dropping out, you have to think of hypothyroidism, hair loss and thinning and drying up. Okay, then cold intolerance. That means that they cannot tolerate cold. Now the exact opposite.
Okay.
So when everyone is feeling hot, they are feeling cold. So it's the other way around. So they cannot, they are using more blankets than usual. Depression. Again, I told you, I get a lot of these patients from psychiatry. I get them from dermatology, and even that's for skin, and from psychiatry. The psychiatry is because of the depressive aspect. Now everything is slowed, even the brain, right? So they come with severe depressive symptoms with hypothyroidism. So that's basically the huge spectrum in which we get our patients presenting.
Join us at Health Talk Desk. Make sure to subscribe, like and share our videos to keep spreading vital thyroid health insights.
So we're talking about hypothyroidism and hyperthyroidism. According to you, or according maybe to the number of patients that you've been able to see over time in Kenya, which one is more prevalent than the other, or are they at par when it comes to hypothyroidism? Because we know, like in most of the Western countries, hypothyroidism is more mainstream than Graves or hyperthyroidism. In Kenya, in our region, which one would you think is more prevalent than the other, or are they at par?
At par, okay. So we don't have really large population-based studies to show which is more prevalent. Actually, this is a condition that is understudied, I would say, in our country. But if you look at studies from Africa, there are a few studies that report the prevalence rates in Africa. So the information we are getting is that the hyper is more common in this part compared to the hypo. So prevalence rates are almost the same, but hyper is actually more. Hyperthyroidism is
good.
more
Yeah.
than hypothyroidism.
Yeah.
Okay. But in Kenya, honestly speaking, I don't think even these figures are truly representative. I think we need bigger studies to be able to understand. As you create awareness through your platforms, and as we create awareness through our platforms, then we could hopefully have more studies in this field, so that we know what is the true prevalence of both hypo and hyper and nodules and all these things within this part of the world.
Okay. Let's talk about the treatment options now. I have enjoyed, because this is a lot of times, this is what I like to advise patients on, the process of from initial diagnosis all the way up to treatment. You talked about patients having maybe psychiatry or mental issues, for instance. They will go see a psychiatrist, but a good psychiatrist, will know very well to want to rule out thyroid disease. So they will send the patient to you, right? So let's talk about what are the treatment options available in Kenya. First of all, as an endocrinologist, we know you just mentioned that you're very few. How do you think the process of a patient that now has listened to you and they can think, maybe I have a thyroid condition, where does that patient start here in Kenya? Where does that patient start to seek treatment before they even come to you, before they're able to reach you? Because you're at the top, but these are patients who walk in. Say we are talking about a patient in Wajir maybe, or in the most inner part of Kenya. They have thyroid disease, or they have seen a goiter, and most of them will think, oh, this thing, the only way to do it is to remove it. We've had patients like that. Yeah. What is the process of the treatment option that is available here in Kenya as we speak?
So the truth is, in Kenya, most facilities nowadays are able to at least detect that there is a problem. Okay? The problem is the awareness of even our clinicians, leave alone our patients. You're creating awareness for the public out there. But it's our duty also to create awareness for the clinicians. So ideally, even the lowest level of the clinician cadre should be able to pick thyroid problems. Okay? Which means that any patient who has the symptoms that we have talked about, even if you don't think, oh, you don't have 2-3 of these symptoms, you're just one of the symptoms, yourself you can reach out to the clinic, right, that's closest to you. Okay? And discuss that with the you can say, I heard that these symptoms could be related to the thyroid. It's now no more an extremely expensive test or an unaffordable, unachievable, inaccessible test. The thyroid screening is done with one test. It's known as TSH, thyroid stimulating hormone. So just to understand, the thyroid gland is controlled by the brain. So there's a part of the brain known as the pituitary gland. It's a small gland which controls now the thyroid gland, and there's a feedback system that works. So when you have got low thyroid levels, this TSH goes up because it is trying to compensate to increase the thyroid levels. When you have got high thyroid problems, then this TSH goes low. Now it's one test. You can even go to any laboratory and request for it. Even today, if all of you have any of these symptoms, just go to any lab and just request for a TSH. It's nothing else. It's not so expensive. It's doable. A good lab, although this is a sensitive test. Some labs do not pick it. So you go to a good, reliable lab and get the TSH test done. So that's basic screening test. Okay. In pregnancy now, we are trying to see if we can actually do this as routine.
Wonderful. In
all pregnant women. It's because we are seeing a lot of issues that are being undetected and that can affect the development of the baby's brain. So that's why this is also coming in. So when detection is concerned, so that is screening. Nowadays, I mean, it's not recommended that every patient or every human being gets screened for thyroid. That's not a recommendation as yet, right? But if you have got any of the symptoms that I've talked about, if your family history is there for thyroid diseases, especially for thyroid cancers, for autoimmune thyroid diseases, then you must get yourself screened. Okay? At least once a year, you just get your TSH test done. If it's okay, well and good, that's fine. At least it's not hypo or hyper. Of course, if there's a nodule or there's a growth happening in the thyroid, then you need to get further evaluation done. So, at baseline, facility level, let's say someone is in Gatundu or in Muranga or in one of these other facilities where they don't have access to a specialist, most of these places have got medical officers at least, right? Or even a clinical officer, which is it's like almost at par like a medical officer, but they're not really like doctors, but they go through this clinical medicine training as well. So they are the ones who run majority of the lower level healthcare facilities in the country. So at least go to one of them and be able to discuss that this is the symptoms, and they would be able to do a thyroid test depending on what they see. If it is low or high, they would request now for further tests. If it is whatever there's a problem, then they request for the full thyroid profile.
Okay.
And probably for a thyroid ultrasound to be able to see if there's no growths in the thyroid, right? And then they would be able to do antibody tests. So it's either at clinical officer level, but let's move to medical officer or even to physician level. Quite a lot of facilities in the country now at least have physicians as well distributed throughout. So if a medical officer cannot handle, then that goes to the level of the physician. So at that level, then now you have to do the antibodies that we talked about, which tells you whether it is autoimmune or not. There is a way you can check the antibodies actually, the soldiers that fight the thyroid.
Okay.
And you get your ultrasound, you get your full thyroid profile. And then after that, the decision is made on what now needs to be done. So if your thyroid is low, mostly the treatment that you require is just replacement of thyroid hormones. Okay? So depending on how much your body will require, you will be put on thyroxine. It's a replacement at one of the thyroid hormones that your body produces. So you're given thyroxine. Okay, and then the dose is adjusted based on how the levels are. So then it's a long-term follow-up, especially autoimmune. So if it's something that we talked about, Hashimoto's, which is autoimmune thyroiditis, that's usually a lifelong condition. Okay, that one doesn't need removal of the thyroid, because if you remove, you are further reducing the thyroid hormone levels. So it's not always surgery that's the option. Yeah. Unless there's a growth in the thyroid gland.
I hope they had that.
And
surgery
it is
never
it's option. Not the only option for treatment, right? Especially your level are low. If you have got just autoimmune thyroiditis or you've got endemic like the iodine deficient thyroid issues. In iodine deficient, you'd give iodine and thyroid hormone, right? To correct that. But again, like I said, it's very rare now in Kenya. I hardly see it. Yeah. Most of my patients with hypothyroidism is autoimmune. Or they've had thyroiditis in the past, they had an infection, and then now they proceeded to get destruction of the some of the thyroid gland, and they get low levels of thyroid hormone. Or they've come in after radiotherapy, for example. Those are the kind of cases we see more commonly. So in that case, surgery is not the option. Okay, so it's thyroid hormone replacement. Depending on your levels, we adjust the doses. Nowadays with Hashimoto's thyroiditis, like I said, there's evidence to show that selenium also helps. So we have been giving selenium supplementation along with thyroid hormones. Okay. Now that's hypothyroidism, right? If you've got a nodule, if you've got a growth, then we get an ultrasound done to see whether that growth is actually benign or it's suspicious of any kind of cancer. If there's any suspicion, so you have to get the ultrasound done in the right facility. Unfortunately, there are very few facilities in the country which actually do the reporting as per the international recommendations of reporting, which includes scoring systems. So there is the British scoring system, there's American scoring system. Like you said, like at the high level facilities like where I work, we can get the ultrasound done and we get this scoring known as TRAD scoring. So in that case, it tells us whether you need to get further tests with a needle biopsy or whether this is benign and it can be followed up by observation only. So if the nodule or the growth is not removing thyroid hormone, then we decide whether we want to do something about it or we want to let it be and just monitor. Okay, sometimes we don't remove it and we just every 6 months to 1 year we just do a repeat ultrasound to see whether it's not growing, whether it's not becoming suspicious, and if it is, then we get it done the fine needle aspirate and then we consider removing it surgically, right? But if it's a goiter, if it's a growth that is causing the pressure symptoms that we talked about, like if it's causing hoarseness of voice, or it's causing difficulty in swallowing, difficulty in breathing, choking, remember the symptoms I talked about? That one is now a surgical emergency kind of. It's not emergency, but it's something that needs to be removed. The beauty with the thyroid, most of the growths in the thyroid are very slow.
Okay.
So it grows gradually over time. It's not like if I don't remove it today, then you'll die tomorrow. Unless there's like a bleeding in the thyroid, or there's some, infection that has happened inside, or for any reason it's just excessively growing, which is very rare. Yeah, it's very rare to get a thyroid gland overnight. But we've got like cancer cases, like there are certain types of cancers known as anaplastic, which is very, very rare generally, especially in this part of the world. Those ones grow very fast. So those ones are surgical emergencies. Yeah. So that one now is the surgical. That's the patients who we would send for immediate surgeries if they are causing pressure symptoms. Now you have got the spectrum of high thyroid, right? Graves' disease, for example.
Yeah.
Now, Graves' disease specifically, it's an autoimmune condition that we said. Your thyroid gland may not be having nodules. It will just be like the full gland is enlarged, right? Or it may be even a normal sized gland. But it's just that it's producing excessive thyroid hormones. So the treatment of that is threefold usually. The first step is medicines, tablets. So they are tablets to quickly or gradually bring down the thyroid levels, okay, depending on how high they are. So the problem with these drugs which we have to monitor is liver functions.
Okay.
And that's important for our viewers to understand. Is there's a reason the doctor will tell you come again, is because they want to check the effect of these drugs. Is it causing improvement first of all? And if it's causing improvement, is it causing any side effects of the drugs, which could be on the blood counts or on the liver?
Yeah.
Okay. So these drugs are good, they work well, but these are some of the side effects that we have to keep in the back of our mind and look out for.
Yeah.
So the first step is always, or most of the time, it is to give your thyroid drugs to try and bring down the levels. The other option for high thyroid levels with Graves' disease is also radioactive iodine therapy. So that means that you ingest a capsule or a liquid which destroys your thyroid gland. It's not radiotherapy, it's radioactive iodine. So iodine goes inside your thyroid gland and it destroys the thyroid gland. Okay? But that cannot be done if your levels are very high or if you've got severe eye issues, because it can further worsen that. Even if we do that, we try to bring down the levels to as low as we can without causing side effects of the drugs. And we try to give steroids at times if there's eye disease, if that's the option that the patient goes for. In certain parts of the world, that's the first option they choose for treatment, rather than long-term tablets.
Okay.
So remember, tablets we can only give up to, we recommend that we don't want to go more than 18 months. That's 1.5 years.
That was going to be my next question.
Yeah, so it's not like a forever thing, right?
Yeah.
But of course, there are some patients who require like 5 milligrams or 1 tablet. Then that's not a patient that you want to take for other options. If they are well controlled on that, then sometimes we continue with the tablets for long term.
Long term means?
Yes, means even depending on up to when their thyroid levels will improve or worsen, right?
But what happens if you remove them? If you remove them from the family?
There are certain patients, actually, about almost up to 50 to 60%, they go into remission with the medicines alone. So I have patients who I start the medical therapy.
Come again, say that again, because I know somebody is going to feel so relieved, because I get those questions all the time.
Okay.
So a patient can get into remission
just on tablets.
Yo, did you hear that? I hope you heard that.
But there's a small percentage, I must say that, and it needs monitoring. So there's a percentage of patients we put on medical therapy, and the thyroid hormone levels over the next 6 months to up to 1 year, they usually go down. But these are patients, there's one more test I did not mention, is there's something known as a radioactive iodine or a technetium uptake scan.
Okay.
Which means that the same iodine in small dose when you take, it can tell you how much your thyroid is overfunctioning.
Okay.
Okay, exactly how much percentage wise. So if your percentage is small and so it's overfunctioning, but it's a smaller percentage, like 1-2%, and there's the antibodies that we check. So if the antibodies are not so high, like not more than 3-4%, then you realize that these are patients who will probably go into remission. We can't exactly predict who will go into remission, but from experience, that's what I've seen, and from figures that we have. But there is a percentage then of patients that actually do not need the drugs after a certain time. They may not need surgery, they may not need radioiodine. Okay, and this group of patients, we actually then, even after stopping, we continue following them. Okay, for long term, because there's always the risk also of relapse, that it can come again. It can go into remission and go back upwards. So that risk is always there with medical therapy. Then now you do radioiodine therapy. Radioiodine will cause destruction of the thyroid gland. The problem with that, or the risk with that, as can be understood, is that it can take the thyroid levels too low. Okay, about 1/3 to about, let's say 30 to 40% of the patients can go into severe hypothyroidism, or very low levels of the thyroid, or generally low levels as well. And majority then need replacement with thyroxine. Okay, lifelong. Another group of patients, smaller group, will go completely into remission. But another 1/3 could go completely into in the sense that they don't need any thyroid hormone after that, or they don't need to go for any other surgeries or anything. And there's a smaller group also that continues to remain in hyperthyroidism even after radioiodine. So that's the group we can recommend a second dose of radioiodine, or now that's the group that would either
go for surgery.
We discuss with them whether to continue with medical therapy or then go for surgery. So it's quite variable. And then if none of this is working, or the patient says, you know what, I don't want any of this, I just want this thing out of my life, So then we go straight on for surgery. But even when we are going for surgery, we reduce the thyroid hormone levels. So we give medicines first. So that's another message I want to send out there, is the doctors should know this, and the patients should know this as well, is that you should not be taken in for surgery if your levels are not under control, because that can be catastrophic.
Say that again.
Okay, so the levels have to be as close to normal as possible before someone is taken in for surgery for hyperthyroidism, for excessive thyroid hormone levels. Because you can have a condition known as thyroid storm, which is potentially lethal. It's actually potentially fatal.
Yes.
That means that it's a very serious condition and very difficult to manage. It needs an ICU setup to handle.
Yeah.
And it's like, you get a sudden release if you have high thyroid levels and your thyroid is being removed. It can release excessive thyroid hormone into the circulation, into the blood. And that is extremely dangerous. It's quite toxic. Patients will have very high blood pressures, very high levels of their pulses. They'll be excessively anxious and all that, and that can make your heart go excessively fast. It's a high risk of irregular heart rates and even heart failure. So we have to be very cautious with that. So before surgery, the thyroid hormone has to be under almost normal levels. In good setups, in very good facilities with really good surgeons, sometimes this condition can be so challenging to manage. I mean, excessive thyroid levels, that you do everything, but the thyroid is just not coming down. So in very selected cases, under extremely experienced surgeons and a good ICU anesthesia setup, sometimes we take patients in with slightly high levels. That's why I'm saying it should be as normal as possible. While preparing, there's another substance we sometimes give. It's known as iodine, Lugol's iodine, to kind of bring down the levels before surgery. We sometimes even give steroids to bring down the levels. So we try to prepare the patient as much as possible. There are medicines to reduce the pulse rate as well, which also helps now with the thyroid hormone. So we bring the thyroid levels to as normal as we possibly can, and then we take the patient in for surgery. So that's one of the options then.
So what I hear you say is that from the initial stages, once a patient has been diagnosed with thyroid disease, then you go to drugs, right? Medication. So surgery should be the very, very last option. Is that what you said?
Not always. Like I said, in certain conditions, surgery can be the first option if you're having pressure symptoms. So even if you have hypothyroid, you have low thyroid, but you have a big goiter, you have a big thyroid gland which is pressing your structures, which is causing you not to be able to eat properly, causing your voice to become hoarse, causing you to choke when you're sleeping, and it's growing inwards. So that's retrosternal. If any goiter that's growing inwards is an indication of doing surgery faster. You understand? So surgery can be the first option also. In thyroid cancers, for example, if you have a growth and we do the fine needle, that's the biopsy of the thyroid, and you find that it's showing features of cancer, then surgery becomes your first option. It depends on how much surgery you're going to do and which kind of surgery for different types of cancer and the extent. Right? So surgery can be the first option in certain selected cases.
Okay.
But if you're looking at, of course, hypothyroid alone, you'll not do surgeries, right? If there's no nodules.
Yeah.
But hyperthyroidism is the one we are talking about. Even in this Graves' disease, there are certain patients, I told you, they can opt for surgery early on. But regardless, we have to bring down the thyroid hormone levels by whatever means that we use with medical therapy.
Yeah. Okay. Well, I hope you're learning. I hope you're taking notes. We're going to go for a short break and we'll be right back with more with Dr. Sokwalla after this. Stay tuned.
Join us at Health Talk Desk. Make sure to subscribe, like and share our videos to keep spreading vital thyroid health insights.
Welcome back. I hope you're enjoying the session. If you have not subscribed, please do so. Now, we go back to with Dr. Sokwalla. As you know, we are here with Dr. Sokwalla, who has given us a precious time to be able to explain to us this thing about thyroid disease. She's delved into so much. She has given a lot of very powerful tools, and I hope that you've learned. Now, we want to have a demonstration. Dr. Sokwalla, talk to us about this illustration here. I can see a diagram.
Yes.
So
this is how the normal thyroid axis runs, okay? So there's this, the axis is known as the hypothalamic pituitary thyroid axis, okay? Big names, you don't need to know them. But just to understand, because what I like is my patients or whoever comes to me to be empowered with why we are doing what we are doing, with the way to read those tests, so that you know why a certain level is high, a certain level is low. Because patients are always confused. Why is my T3 low and why is my TSH high? So what do I have? Is it low, high, right? So in the brain, there's these two structures known as the hypothalamus and the pituitary gland. The hypothalamus is the father structure, okay? It controls the pituitary gland, okay? So from the hypothalamus, there's a hormone known as this TRH that is produced, which goes to the pituitary gland, and in the pituitary gland, it stimulates. So pituitary gland is actually a master hormone gland, which is involved in the control of a lot of hormonal functions in the body. It controls your reproductive system, it controls your stress response, it controls the breastfeeding aspect for women, and a lot of other functions, okay? And one of the hormones that's produced from the pituitary is known as this TSH. TSH is the thyroid stimulating hormone. That means that it stimulates the thyroid to produce thyroid hormones. So the TSH actually comes and sits on what we call as receptors, but imagine that they're like small chairs on the thyroid gland that this TSH is coming and sitting on. So it sits on that and it gives a command to this thyroid gland to produce excessive, or not to produce hormones, basically, not excessive in this case. This is a normal profile that we are talking about, okay? So it causes the thyroid gland to produce T4 and T3. They've got really long names, which of course you don't need to know. But just remember T4 and T3. Most of the hormone produced is the T4, which is changed into T3 in the liver and the muscles. Now the T3 goes and it works on different parts of the body, like we were discussing the heart, to increase the heart rate, to control rather your heart rate, your heart contractility or functioning. Works on the liver to control your liver function, on the bone to control the bone turnover, and on the brain, amongst other organs like the reproductive organs as well. Now there's a beautiful negative feedback loop. So normally when you have your T3, T4 produced, they go back to the brain and they give a message to the brain that we are enough. So what will the brain do? You see this negative feedback. It's called negative feedback. So the brain will reduce the level of the T3, TSH and the TRH. And that's how everything is usually under control. And that is why when there's a problem with the thyroid gland, for example, the thyroid gland cannot produce enough thyroid hormone with the conditions that we talked about. Either there is destruction or removal of the thyroid gland, or there is autoimmunity. Then what happens is you've got low levels of T4 and T3, right? So they'll go to the brain and give a feedback, and the brain, what will it do is to try and increase the production.
So
your
TSH
TSH will be high.
Got it.
So TSH will be high, but your T3, T4 can be either normal.
Okay.
When the brain is able to force the thyroid to produce extra hormones.
Yeah.
Or your T3, T4 will be low if that capacity is not enough, and your TSH would be high. That is hypothyroidism due to the thyroid.
Okay.
Or you could have hyper, which is now the opposite. So if you got excessive T3, T4, either release due to an infection, like I was saying, thyroiditis, or due to something like Graves' disease, where you have excessive production. So there's excessive release or there is excessive production. If there's excessive production or release, what happens is your T4, T3 will be very high. Yeah?
Oh, there's a difference between release and production.
Yes.
Got it.
So thyroiditis, which we are talking about, which could be due to viral infections, or even due to radiation sometimes, you can get inflammation and release of the thyroid hormone.
Got it.
And that's temporary. Whereas Graves, which is excessive production, or a nodule which is excessively producing, is called hyperthyroidism. It's excessive production.
Okay, got it.
So there's a very big difference. And the reason why we need to know the difference is because the treatment is totally different.
For the release and the that is so important. I hope that you really caught that. There's a difference between the production and release.
When there's excessive release, usually that's temporary. So that one means that your thyroid releases excessive thyroid hormone in the blood. Yeah. And then so there's a phase of excessive thyroid hormone levels. Then because it has released everything, the levels drop down. So you get hypothyroid, and then after a while it normalizes. So this can take even several months. But that one can normalize. Okay. About 10 to 15% continue with low thyroid levels. The one I was telling you is when you don't really know the cause. It could have been this, right? You get infection or inflammation. There's destruction of the thyroid tissue. There's no adequate compensation once the destruction has happened. And there's some level of percentage that remain low.
I think you've just hit jackpot. You've hit the nail on the head, because I can tell you for sure, many physicians, many clinicians that are treating don't know the difference.
Yes.
So when it comes to the treatment, they can treat with the same medication, but now dealing with a professional who understands the difference between the two, the approach is different.
It's very different, and
totally
that's why
different. I get
when
it
we do
now.
the uptake scan, the technician scan that we are doing here at Aga Khan is doing, even I think Nairobi Hospital have brought it. There's some facilities within Kenya which are now doing it, which tells you now if the uptake is not increased, then you know there's destruction that has happened. Then you don't need to give your thyroid hormone, the medicines, you see. Yeah. Then the medication will be different. You don't go for iodine, you don't go for surgery. Then you know you are in the track of probable temporary disease. Your antibodies will also be negative. Now what happens is, if your levels are high, they go and suppress. They go and they tell the pituitary gland, we are too high. Yeah. So the pituitary gland, what will it do? It will reduce your level of TSH. So that's how your TSH will be low and your T3, T4 will be high. In cases of hyperthyroidism or thyroiditis, when you've got excessive thyroid hormone in the blood, then that is what you see. So that's important for our patients out there to know, so that they understand the difference between a low thyroid and a high thyroid, and what these tests exactly mean. So you may have a low TSH and a high T3, T4, which means your brain is like your thyroid is overworking, it's producing excessive thyroid hormone. Whereas you have a high TSH and a low T3, T4, means that your thyroid is low in producing thyroid hormones. Okay. Is that clear?
Very clear. Good. Very clear. Very, very clear. Oh, wow. I hope you're learning, guys. Yeah. And in time, once this video comes out, we want to see your feedback. We want to see you sending in your questions down on the comment section. Yeah, so thank you very much for that explanation. I feel enlightened, actually. So as we wind up, I wanted us to talk about the misconceptions that are there. But before the misconceptions, let's talk about thyroid disease and fertility, because I think that is an aspect that is very underlooked, I think. And patients, I will have patients sometimes coming in and say, I've miscarried once, twice, 3 times, and they don't understand why until we tell them, just go try and check your thyroid hormones. What is the connection between thyroid disease and fertility or pregnancy?
Yeah. Great question, because you see, like I told you, thyroid has its function on, the thyroid hormone has its function on multiple organs of the body. And one of them is also fertility, and not only fertility, menstrual cycle itself. Okay? So whenever a patient even goes to a gynecologist, so we, like I told, we get referrals from very many different areas of medicine, psychiatry, dermatology, even gynecology.
Yes.
So patients who have had irregular menses or excessive bleeding or very little bleeding, one thing to test for is the thyroid hormone, okay, the thyroid profile, because that is strongly associated with disturbances in your menstrual cycle and fertility. Because if your menstrual cycle is not okay, then of course the risk of infertility is very high. And then again, the risk of miscarriages if it is not well controlled. And that takes us now to pregnancy as well, right? So any woman who's not able to conceive, one of the tests in the workup must be the thyroid hormone. That's is like mandatory.
Yes.
Yeah. So when you're getting workup done for fertility, you have to get your thyroid hormone levels. If you're getting multiple miscarriages, another reason why you have to get your thyroid hormone levels checked, like you rightly said, it can potentially lead to loss of pregnancy and also to infertility itself in the first place.
Okay.
And I have patients, what's beautiful is I have patients who you just put on a small dose of thyroxine, and actually you realize within 3-6 months they're conceived.
Pregnant. Yes.
And we help them now through pregnancy also, because that's another huge challenging area to handle the thyroid hormone levels in patients who have got thyroid problems or who develop them in pregnancy, where you have to be a bit more cautious. You follow them up a bit more closely and make sure that the levels are within range,
yes.
so that the pregnancy progresses smoothly, because the aspect of pregnancy losses and complications during and after pregnancy with the baby also are quite high if the thyroid levels are not well controlled.
So do you advise that even after pregnancy there's follow-up even for the baby?
Yeah, definitely.
For the baby.
So nowadays the recommendation is that every baby should get a thyroid hormone test done.
Music to my ears, yes.
That is, if you can, you should get your baby checked for thyroid hormones at birth. Because missing that can cause catastrophic situations, right? But especially in women who have got thyroid disease, of any form, in pregnancy, the baby has to be checked at birth.
At birth.
Yeah, and then of course you'll monitor with the pediatricians can monitor and see if there's need to repeat further. If it was normal, most of the times you don't need to. But if there's a problem, then they can consider repeating, or if there are certain symptoms that the baby is demonstrating, then they can consider following up for that in the baby as well.
So in other words, you are saying that early detection, would you advocate for early detection, especially for patients that, if say I get pregnant and I'm a patient, would you advise that I just go get my thyroid hormones checked?
So if you are entering pregnancy,
even before I'm entering
knowing
pregnancy,
you have a thyroid problem, then you must get your levels checked at the moment of detection. Ideally, this is one thing that I want to emphasize, not only with thyroid diseases, but also other conditions, any conditions, right? Like if you have a heart problem, if you have got diabetes, if you have got kidney disease, don't become pregnant without discussing with your doctors. So basically, this is known as preconception preparation or preconception counseling. So you have to plan your pregnancies. You avoid becoming pregnant before you have got the green light from your doctor.
Okay.
You understand? Because like diabetes as well. Since I have the opportunity, I think I'll tell our viewers out there that even if you have diabetes, you have diabetes, you have thyroid disease, please discuss with your doctor well in advance that you're planning a pregnancy, so that they can guide you through that, because the levels that you want to achieve for pregnancy are different compared to the levels that you want to get without pregnancy. Certain drugs are not safe in pregnancy, or the safety is not known. So you want to change your drugs to what is safe in pregnancy, There are certain medicines that we add, like folate, in high-risk mothers who are planning to become pregnant. You see, these are high-risk mothers. Actually, if you've got diabetes, you've got thyroid disease, you've got heart disease, this is a high-risk pregnancy already that you're looking at, even before you become pregnant. So you must discuss that with your doctor and get things under control before you become pregnant. Till then, go and see a gynecologist to help you with contraception. Okay? But you should be well controlled before you become pregnant. So if my patient has a thyroid condition is actually planning pregnancy, what I'll do is I'll make sure that the thyroid levels are well under control. Let's say if it's a patient with low thyroid levels, like hypothyroidism, then we want to keep the levels a little bit higher than what you would if you're not planning a pregnancy. Because thyroid hormone is required for baby's brain development, which occurs, and even the other organs, neurological organs and other organs, development occurs in the first trimester, which means in the first 12 to 14 weeks. And early pregnancy, like even earlier than that, about 8-9 weeks, you start getting brain development. So if you don't take care at that time, then you've already messed things, and then now you are trying to control them. You see, so I would make sure that the level is a bit high. So before pregnancy, we want the thyroid hormones to be on the higher border of upper normal, right? Even during pregnancy, throughout pregnancy, we want to keep the T4 that I was telling you, we want to keep it in the upper border of normal. Okay, and the TSH low. So we try to achieve that as best as possible before the patient is allowed to become pregnant, or rather plans pregnancy. Okay? Now during pregnancy, again, your baby's requirement is very high for thyroid hormones because of the simple fact that the organs develop with the thyroid hormone. So now even in that case, we have to keep the levels higher. So you may realize that when a patient comes to me, I'm increasing the doses at every visit, and that's the reason. It's not that the doctors don't know the dose, but it's because pregnancy, the requirement is higher, so we increase the dose as the pregnancy goes on.
Accordingly,
Yeah, you may require even up to like 3 times of what you needed before pregnancy. Someone on 50 micrograms may end up being on up to 150 by the time they are delivery or before their delivery. And then this has to be followed up even after delivery, because now your requirement goes down. So we have to then reduce the doses accordingly to your pre-pregnancy doses. But slightly higher maybe because of the breastfeeding aspect and all those other things, because you've gained weight as well. When it is high thyroid levels, that's now another interesting situation. We have to change your drugs ideally to what would be the safest, especially in the first trimester, because there's drugs for high thyroid is like carbimazole. We change carbimazole to something known as PTU. Okay, so that's why also they have to see their doctor if they are on medicines for thyroid, hyperthyroidism, like Graves' disease, right? Where we change the drugs to safer drugs in the first trimester. There are certain drugs we remove as well. Now what happens is we monitor again. The good thing with Graves is the other way around, because the requirement in pregnancy is high. Many times you see that the levels are going lower. They are better than they were. A lot of my patients don't need medicines during pregnancy for hyperthyroidism. Another interesting condition in pregnancy, and it would be good for our patients to know, is a lot of pregnant women without having any thyroid disease develop high thyroid levels in the first trimester or in the beginning of pregnancy, which causes this excessive vomiting that you get in pregnancy. Hyperemesis, you know, that some women get excessive vomiting. So that is known as transient thyrotoxicosis of pregnancy, which means that it's just transient, it's short term. And many colleagues or many clinicians might put the patient on thyroid suppressing drugs, you know, to reduce the thyroid hormone levels. And then the levels can crash down after that, so after the first trimester. So always when you're having excessive vomiting, thyroid hormone has to be checked for, number 1. If the thyroid hormone is high at that time, there should be some tests to confirm what is the cause of that excessive thyroid hormone before treatment is begun. Just supportive treatment is usually given to reduce the symptoms, you know, of thyroid hormone excess. But that doesn't need necessarily thyroid drugs. It usually treats itself during the later parts of pregnancy.
So it regulates itself? And
it just comes down. Okay, it's just the excessive response of a normal pregnancy. In normal pregnancy, your thyroid hormones increase because of the hormones of pregnancy. All right? So that's something to know. Now, if you had Graves' disease, then again your requirement might go down of the thyroid hormones. But after delivery, You see, like I have got, even now as we speak, a couple of patients who are pregnant and are not requiring any medicine. If anything, the levels are so low, sometimes I have to even give thyroxine, you know. To that extent, yeah. But the levels tend to go low in pregnancy because of the requirement. But after delivery, that has to change. Because now again the thyroid will overfunction, come back to its pre-pregnancy level.
State, yes.
So then the doses have to be adjusted. So you must see the physician or your doctor that you're following for thyroid disease immediately, even after pregnancy, and repeat the levels within 1-2 weeks to see which direction it's going in, and to monitor thereafter to see if there's need to restart the thyroid drugs.
Okay.
Yeah.
So, Dr. Sokwalla, as we wind up, I just wanted you to help us know, how can patients advocate for themselves? What we do here at Health Talk Desk is empower patients, right? And I don't know, sometimes I tend to pose this question to doctors. Would you rather deal with a patient that is just, you know, a yes doctor kind of a patient? They don't want to take initiative on learning and everything. Or would you rather want to deal with a patient that is empowered enough, especially in cases of thyroid disease? Understanding that thyroid disease is a very huge, you know, it's a huge topic by itself. We couldn't even cover a lot of the questions that are coming in. So what would be your last clarion call, maybe, to the people, to the patients that are watching, so that they can know more about this disease called thyroid disease?
So I think as TDAK, you're actually doing a brilliant job already in creating awareness. The first step always comes with knowing, right? Okay. It's with knowledge, it's with education, and it's with awareness. So if you or your loved ones or your family, your friends, you know, have any aspects or any symptoms that we have talked about, or even no symptoms, you become a patient advocate, right? If you have yourself thyroid issues, then preach out there, right? All my patients, even with diabetes, I tell them, you now have become the advocate for us, because I can't reach out to each and every person out there. So first of all, definitely I would like a more informed patient to come into my clinic, who knows a little bit already about what thyroid disease is, what is the you know, a bit of what are the causes of thyroid disease, the symptoms related, what is it that they may be having. So it's always good to get an empowered patient coming in to see us. But what I was saying is also out there as patient advocates. Every patient, I believe and strongly try my best to make them become a patient advocate, because your journey may help someone else to pick their condition early on, to reach help early on, and to be treated much early on before the complications develop, because these conditions, they have their complications as well, right? And even through the journey is to keep learning and keep understanding what's going on with you. So not blindly saying, okay, so this is your, you know, sometimes you go to the clinic, you're told, some patients I even see, even though I'm willing to teach them, they're like, doctor, you just tell me what I need to do. You know, just give me the medication, I trust you, and that's it. But is that what we want? Or what we want is you to be empowered with what you are going through, to be able to understand why I'm giving you what I'm giving, and take charge. You be part of the decision-making process for your treatment as well. So definitely what I would advocate is understand what is thyroid disease. If you have thyroid disease, make sure you ask your doctor, which kind of thyroid disease do I have? What does this mean? What are the risks for this, as far as the risk of cancer is concerned, risk of cardiac heart complications, other complications, my fertility risk? Reach out to the doctor even as yourself to take that initiative to understand it better. And then teach others. Okay, and that's what you are doing. Today you are teaching more than thousands of people out there on what thyroid disease is. And it's not something to be ashamed of. It's not something to hide under and say, no, you know, I don't want people to know. Talk about it. It's a condition that can be treated, actually. And you know that. Who knows that better, right? So it's a condition that is treatable. So reach out for help and basically talk about it. We all must talk about it to create awareness.
Everybody that is involved, every stakeholder, every duty bearer, everybody, we have to work as a team. I cannot say how grateful I am, honestly, to just say thank you so much for taking the time, for inviting us into your space, for talking to us. I know there have been very, very many little nuggets that have been shared. We have so many questions coming in, guys. So we want you to stay tuned for the second part of this session, where again our very own Dr. Sokwalla will be answering the questions. So stay tuned. If you have more questions, please just type them on the description box hapo chini, send your messages, and also get in touch with the HTD team, and then we'll be able to get back to you. Thank you so much for taking the time to be with us today. We are grateful that you have spared your time to watch this and share it. Make sure you share it. This is very informative. Share it. And so I've been your host, Soira Sokwala, and I hope and wish to see you the next time. For now, it's bye-bye for all of us here at Dr. Sokwalla's house. Bye.